with two risk factors to being last in the session. A certain amount of overlap is inevitable. I hope you'll bear with me. And secondly, of course, I'm standing in a hazardous, dangerous place. I'm standing between you and your next cup of coffee, so I'll try and move along reasonably quickly. This is a year of anniversaries. It's the 100th anniversary of a rebellion in Ireland, which resulted in the original Brexit, leaving Ireland. And then, of course, more somberly, it's the 100th anniversary this month of the Battle of the Somme, which was such a human tragedy, and the 10th anniversary of this small, limited, retrospective study which suggested an association between the use of propofol and paravertebral anaesthesia during breast cancer surgery and compared with balanced anaesthesia with vapors and opioids in breast cancer patients, which I think it's fair to say started a journey which many of you have joined in on, and it's probably fair to say that for it's approximately 60-40. If this was a game of football or basketball, I think it's fair to say that about 60% of all the retrospective studies on all the solid tumours that have been looked at suggest a positive association, and 40% suggest no such association. And they're still coming through. This isn't even a complete or up-to-date list. But we're on a research journey, a journey which begins with this question: can the anaesthetic make a difference to cancer outcome? And which will really only be addressed and answered by prospective randomized controlled trials, which are a pain in various places in our anatomy because, of course, the primary outcome is recurrence or metastasis, and therefore long-term follow-up is mandatory. But in the meantime, we've been looking at and hearing all day about wonderful cell culture evidence, live animal model evidence, some further retrospective clinical studies, and translational studies. By that I mean data, laboratory studies based on or sitting on the platform of clinical studies. So, for example, an ongoing randomized trial taking samples of blood or cancer tissue from patients and going back to the lab and evaluating relevant factors around them. And all of this adding up to a biological plausibility around what may be going on in the perioperative period. So what we're about is trying to judge, as we move from a normal cell to whatever happens to it, a cancer cell, which clumps together and forms a tumour, which eventually draws symptoms from a patient, and from which we as doctors elicit signs, for which surgery is indicated, and the surgery happens, and the primary tumour is removed, releasing these circulating tumour cells. And so many of these perioperative factors we've been hearing about can influence whether these circulating tumour cells just die out or in fact take hold and blossom. And among the many perioperative factors which we've mentioned, like immunosuppression, activation of various cytokines and angiogenesis, is regional anaesthesia and our anaesthetic techniques and drugs in general, but regional anaesthesia in particular can have a central role in this, in whether these circulating tumour cells might take off or not. And if we want to be, and if we decide we're going to be, if you were a metastasizing circulating tumour cell, you need to be able to do certain things. You need to be able to invade through the walls of tissues. You need to be able to go forth and multiply, proliferate, migrate. And that migration takes place into blood vessels and into the lymphatic system, as we've heard this afternoon. And then the processes are reversed in distal tissues. There's invasion, there's migration, proliferation, and angiogenesis, which, if single cells can do this in multiple cells and multiple locations all around the body, one can see how the horrible process of metastasis takes place. So how could we counter this? And of course, if we take the balance of forces going on between tumour promoting forces and anti-tumour forces, the tumour promoting forces, as we've heard, again, the stress response to surgery, pain is bad for us. Opioids, a bit more controversial, but might have detrimental effects. Volatile agents, as we've heard, may well have detrimental effects, at least if you're to believe the biological plausibility. On the anti-tumour side, we have our immune function, particularly natural killer cells, and perhaps the direct effects of some of the drugs we've been hearing about, including amide local anaesthetics. But regional anaesthesia, we know, will attenuate the stress response to surgery, will give us a great quality of pain relief, and in doing so might attenuate the amount of opioids and the amount of volatile agents that we need. And perhaps our amide local anaesthetics, if they're not acting through the block itself, perhaps they're acting through systemic absorption to create this hypothesis that perhaps our regional anaesthetic technique and or a direct effect of our amide local anaesthetics might affect recurrence or metastasis. And once again, the key message that we've got to take away with us is that this question can only be addressed by prospective randomized clinical trials. I'm involved in one of them, and this is some data from that prospective randomized trial on breast cancer, propofol paravertebral versus sevoflurane opioid. But before you get too excited, I'm afraid it's very preliminary data, and none of it has to do with cancer outcomes, which we're all interested in. All I can tell you is the study's been going on since 2008 with no formal funding, based on the goodwill of 7 or 8 centres around the world, including Cleveland Clinic, ourselves in Dublin, University of Vienna, and Peking Medical College in China, and more recently a centre in Auckland. And all I can tell you is that we're setting out to do what we're trying to do in terms of creating 2 groups. So our analysis of some 350 of the 2,000 patients enrolled to date suggests simply that we're creating 2 different groups in terms of different pain scores. So, surprise, surprise, the patients who get a paravertebral regional block as part of their anaesthetic technique have less pain than those who have a balanced opioid-based technique. And of course, the group that's meant not to be getting opioids, or guess what? They're getting statistically less opioids than the group that are. And on the other side of the equation, the group that are getting predominantly Ativa-based anaesthetic are getting more propofol than the group that are not meant to be getting much propofol except at induction. So what I can tell you about the ongoing randomized trial on breast cancer recurrence is that the trial study has successfully created 2 groups with different pain and with different doses of drugs. And if our hypotheses are valid, that these things make a difference to cancer outcomes, then we should be able to show such a difference. But at the end of 1 year, all we can conclude is that we should continue with our work. It's too soon to say. Basically, not enough recurrences have occurred, or not enough recurrences have occurred early enough. If you want to join this, come and talk to me afterwards. The Guinness will be on me. But while waiting in joyful hope for these trials and others that have been briefly alluded to, there are other sub-questions. So can we draw any conclusions from FARCs, from follow-up studies of previous randomized controlled trials that were set up to look at something else? Or should we, in fact, if we had it all again, just listening to Juan there summarising Tobias Spiegler's work and the others' work, if I had it again, if we could switch the clock back to 2006 again, would I have the same study of propofol paravertebral versus Sevo opioid? Probably not. I'd say the study we should do next would be IV lidocaine versus placebo during whatever you like, probably colorectal cancer patients or any other type of cancer patient, and simple, pragmatic, randomized study. Will you join me in that in our cost group? You know, the only way we're going to get people outside our specialty, or even ourselves, to believe this is if we generate prospective, randomized controlled trial data. And what evidence is there from ongoing translational studies, and what's the biological plausibility of this hypothesis from experimental lab data? And I think this afternoon and today is showing us that it's really pretty convincing. Back to follow-up studies, follow-up analysis of previous randomized trials. Perhaps the best of them is this work from Paul Miles' group. Many of us, or some of us in the room, are old enough to remember the MASTER trial. 15, 16 years old now, published originally in the Lancet actually, and set up to randomise patients to get an epidural or not to get an epidural for major surgery. Not necessarily major cancer surgery, just all-cause major surgery. And as many of you will remember, it was rather disappointing to those of us who would like the concept of regional anaesthesia to be better. It found no difference in mortality, but perhaps the epidural group had a reduction in respiratory morbidity, pneumonia, that sort of thing. Paul and his group went after the patients who happened to have cancer as the indication for surgery originally, and came up with approximately 240 in each group who had or who had not had an epidural during that study. and analysed them in terms of cancer follow-up. And what did they find? The Kaplan-Meier survival curves are overlapping. No significant difference at all. So that wasn't encouraging, but we'll have to remember that this was designed to evaluate not cancer outcomes, but in fact other outcomes altogether, including mortality. So what about any data from other, if you like, translational studies? And we have heard today about the importance of the immune system, in particular natural killer cells. So I had my group take serum from patients in the randomized controlled trial of propofol paravertebral versus balanced inhalational opioid study. We simply took blood before and after, the before anaesthesia and the day after, and went back to the lab with that. To do what exactly? Well, we're familiar with tumour cells, and we're familiar with the idea of cell-mediated immunity, particularly natural killer cells being important. And natural killer cells render the tumour cell antigenic and therefore draw antibodies to it to eliminate it. And when they're activated, they, well, produce activatory receptors called CD16s, and they also release cytotoxins which kill tumour cells, and if they do so, they leave behind a footprint called CD107A markers. So essentially, we took a few patients from the ongoing trial, took pre-op and post-operative serum, and went back to the lab to look at the patient's natural killer cells, to look at the activatory receptors, cytokines, and the level of cytotoxicity. And in a nutshell, without boring you, because I know you're getting really desperate for the coffee, as am I now, but in a nutshell, we took 10% serum because that's what worked, added in the natural killer cells, co-cooked them, if you will, with breast cancer cells, and after 24 hours of incubation had a look for some of these outcome measures reflecting the activity of the natural killer cells. And what we found is essentially that between pre and post-operative serum in the propofol paravertebral group, no change in the expression, in the activation of the natural killer cells, but something about the serum of the patients who had the balanced GA was attenuating or inhibiting or reducing the amount of natural killer cell activity, overall activity. And when you look at actual cytotoxicity as measured by CD107A, something like the reverse was happening, in that the propofol paravertebral serum seemed to confer, by some mechanism, a way of increasing natural killer cell cytotoxicity compared to no such change in the group who had, if you like, the balanced GA, suggesting that anaesthetic technique, in a way, in a mechanistic way that I cannot explain for you, is providing serum conditions which were conducive to maintaining natural killer cell function, which in turn were hopefully resisting or contributing to the resisting of spread of metastasis. And we've heard about amide local anaesthetics already. We know how they work. We all learnt originally that, of course, they work by sodium channel blockade. And in fact, Tim Hill's group have shown that that's good, because not only are they sodium channel blockers to block pain, which is what we want, but in fact, it turns out that colon cancer cells migrate with the help of a sodium channel blocker, and that if we provide amide local anaesthetics, whether absorbed from our regional techniques or given directly, it is likely that the amide local anaesthetics will stop colorectal cancer cell migration. But as we've heard, it doesn't just stop at that. There are anti-proliferative effects of local anaesthetics that affect endothelial cell function as well. And essentially here, this data which you've seen before, the darker histograms reflecting the higher concentration of amide local anaesthetic, in this case ropivacaine, showing that the greater the concentration of amide local anaesthetics, the greater the inhibition of proliferation of cancer cells, and more clearly seen here, higher concentration of ropivacaine, less dots, less proliferation of cancer cells, and that, as we've heard, is attributable to the inhibition of the SRC or SRC signaling mechanism intracellularly. And then again, separately, an entirely different group, again, from Philip Lurk and Marcus Holman's group, showing that lidocaine has a beneficial effect to murder or to prevent DNA proliferation in breast cancer cells and not other cells. And essentially the gist of this is that tumours only get activated when in fact tumour suppression genes fall asleep. and it turns out that in cancer, methylation is a very important adverse event, that the methylation of groups, the addition of methyl groups to DNA renders tumour suppression genes inhibited, such that there's a free process for the tumour to go to tumour activation. Lidocaine demethylates the cancer cell DNA, so cancels out this effect, thereby switching on the tumour suppression again. So if you like, it switches off the switcher offer, if I haven't completely lost you. In other words, inhibits the inhibition of tumour suppression genes to switch on tumour suppression once again, the tumour suppression genes once again inhibiting tumour activation. So perhaps we should be looking at lidocaine IV. The trouble, why don't we just get on and do it? Well, because we're lacking animal data. The funding bodies, the funding bodies have made a career out of rejecting my grant applications, but the current reason is because I haven't got animal data. So with thanks to the ESA and some other funding bodies, I'm trying to get that data now, and we have a very simple 41 mouse model, and we have been working with some difficulty, but we have got the model working. We've had a number of groups, including lidocaine with sevoflurane, lidocaine without sevoflurane, lidocaine with another IV agent. Very hard to give propofol to a mouse, actually, but we've come up with an IV agent with and without lidocaine, and we're looking forward to analysing that data within the next month or so. Can I put in a plug for this collaboration? It used to be, well, we're all competitive. We all need to stand up and be counted in our universities. But one of the innovations this year is that the EU has funded the collaboration that we're all here for. So I essentially put in a submission to the EU Cost Action Programme, which was funded this year. Cost does not mean money in this context. It means collaboration in science and technology across all disciplines. And essentially, I put forward a proposal based on what we're all here for today. Essentially, we call it the European Platform for Research Outcomes, Perioperative Interventions After Surgery for Cancer, translated as EuroPeriscope as an acronym. And it simply means that they fund the collaboration. They fund the coming together of those of us who are interested in this topic to advance the thing. So I urge you to join it, please, and I'll put up the website. It won't cost you anything financially. If you come to the meetings, you'll be reimbursed by the EU, and it just means that we can get together and plan the next steps together, with particular emphasis on European countries, but we are allowed to have international partner countries as well. So those of you from the United States and Australia are more than welcome as well. So in summary then, before you go to your coffee, of course, there are retrospective analyses suggesting an effect of regional anaesthesia on cancer outcomes, and when they're aggregated in meta-analyses, which is a bit wishy-washy, are you allowed to do meta-analysis of retrospective studies? It's not the best quality, but it does suggest a signal there. But we need to do our prospective randomised trials. There are some positive signals, biologically plausible signals, from some serum studies around the prospective randomised trials, and there is biological plausibility from the basic science, which we've been hearing about all day. Have a look at that website, and please consider joining us and lending your ideas, because look, we can't do this on our own. And I'm hoping that this cost action could be a platform for perhaps application for properly funded European H2020 funding that will really help us get the evidence we need to address this. Thank you very much for your attention.